Guidelines generally recommend watchful waiting for aortic valve replacement until symptoms emerge in asymptomatic patients with severe aortic stenosis. However, until now, there has been no large-scale multicenter study comparing initial surgical versus conservative strategies in patients with asymptomatic severe aortic stenosis. We're going to take care of that now. And we are looking at a first report. It is going to be, Jack, online before press, so it is presented here at TCT, and for that I am with Dr. Tomohiko Taniguchi, who is an MD and from Kyoto University Graduate School of Medicine in Japan. First, you're using the current AS registry. What is the current AS registry?
So current AS registry is a multicenter retrospective registry enrolling 3,815 consecutive patients with, who met the definition of severe AS for the first time during the study period. And severe AS was defined according to current guidelines. And at the index echocardiography, 1,808 patients were asymptomatic. And the asymptomatic patients were subdivided into the two groups, the initial AVR group and the conservative group, according to the treatment strategies.
And so you ended up also with a propensity score match cohort,
Yeah,
which was a little smaller but important.
Yeah, because baseline characteristics in the entire cohort were significantly different between the two groups. Patients in the conservative group were much older, 78 years old and 72 years old, and had higher STS score, 3.5% and 2%, and more often had comorbidities such as prior stroke or coronary artery disease. So we developed a propensity score match cohort of 582 patients as the main analysis set.
So let's talk about the crude clinical outcomes in the entire cohort first. So what did you find?
So the cumulative 5-year incidence of all-cause death was significantly lower in the initial AVR group than in the conservative group. And the cumulative 5-year incidence of heart failure hospitalization was also significantly lower in the initial AVR group than in the conservative group.
So the propensity score matched, was that pretty much the same, or did you have find a difference?
So the favorable effect of the strategy, the initial AVR strategy, compared with the conservative strategy, we're seeing in both propensity score match cohort and the entire cohort.
Wow. Now, one of the points you make in the paper, which I thought was very good, because we're talking about, watchful waiting, but you make the point, patients may not always be compliant to close clinical follow-up.
Yeah, definitely.
That may be one of the things to explain the difference you're seeing.
Yeah. So, one of the most important findings from our registry is that among 1,570 patients, 30% patients became symptomatic. And among these patients, near class 3 and near class 4 severe heart failure were seen in 40% of these patients. And if you look at the AVR rate, AVR was less frequently performed in patients who presented with near class 3 and class 4 heart failure than in patients who presented with near class 2. So probably AVR was not referred to, some of the patients was not referred to AVR because of their bad clinical conditions.
Right. I mean, you note in the paper, the initial AVR strategy was associated with markedly lower risk for heart failure hospitalization, which should be regarded as a very serious clinical event in patients with severe AS. So what's your take-home message?
So, of course, further RCTs are needed, but the long-term clinical outcomes of asymptomatic patients was dismal when managed conservatively in real-world clinical practice, which might be substantially improved by the initial AVR strategy.
Well, please, we have so much coverage from TCT that's going into JACC or JACC Interventions. Please check online on both of those publications. And for CardioSource World News, I'm Executive Editor Rick McGuire.